Thank you, Mickey, for that lovely introduction. Thank you for the honor of being here today, and thank you for the joy of being able to be in Tel-Aviv. This is really quite special for me. It's also a treat for me to be able to be here and to talk about my favorite subject, namely sex and the brain. And for those of you like me who have very short attention spans, I've taken the liberty of summarizing my entire talk on the first slide, so you can fall asleep thereafter, no problem at all. And it says, looking for this, it says, admittedly, it's a complex situation fraught with dangerous implications from conflicting interpretations of the facts and the pressure of historical enmities, but I'm sure I could come up with something if only I could remember what it was we were talking about. So what I will be talking about is the way in which reproductive steroids can provide remarkable insights into affective regulation, and by so doing answer what is arguably the most important question in psychiatry, which is why do different people respond differently to the same stimulus? So let me begin with a question, which is, if we know so much about neurobiology, why do we know so little about depression? So there are lots of reasons. One, tremendous diagnostic heterogeneity. Depression that occurs in a 16-year-old girl who breaks up with her boyfriend is not the same as the depression that occurs in somebody with pancreatic cancer, nor the same as someone who is 75 years old and develops depression. These are different disorders, we give them the same name. Associational studies tell you nothing about cause, obviously. Group data, the problem with group data is revealed in my first very high-tech slide. Namely, that within group data there can be meaningful subgroups, the significance of which is totally obscured if you look solely at means among groups of individuals. Most of the studies, particularly the imaging studies, employ a myriad different stimuli, cognitive stimuli, physiologic stimuli, a million different cognitive stimuli. It's very difficult to get consistency in findings across the literature. Cross-sectional physiology fails to distinguish between pathological changes versus compensatory changes versus pure epiphenomena. And then finally, what the bulk of my talk will be about, which is context. And it's about context because all of physiology is context-dependent. Every single physiologic event cannot be interpreted outside of knowing what the immediate context is. There are obvious developmental stage effects, that is to say, there are windows of plasticity, so-called critical windows, during which time a stimulus will produce a response, often enduring, that will not be seen if that stimulus is again administered outside of that period of, outside of that critical period. So this was demonstrated initially in a classical paper by Charles Phoenix and W.C. Young's lab in 1959, in which they observed that prenatal administration of testosterone resulted in the females growing up, and then once they were re-exposed to androgen, they acted like males. They would try to mount the other females, they would become very aggressive. This is also shown by Roger Gorski and others. And this was identified as an organizational effect of the brain. So again, this administration of steroid during a very critical period changed the way the brain would respond to that stimulus ever after, but particularly after puberty. There are effects at the other end of the age spectrum. Everybody, everybody knows that there are cognitive changes, for example, that occur during aging. Hi, I'm, you'll have to forgive me, I'm terrible with names. Also, I'm sure I know what you've got, Mrs. Martens, and it begins with E. So, some of us are unfortunately all too familiar with this, but the question is really, do these behavioral changes that occur during aging have any relationship to reproductive endocrine changes, or are they entirely independent? And can the effects of hormones vary with age? The answer to both of these questions is yes, which I'll come back to momentarily. There are obvious sex differences. This whole conference is about sex differences, right? And this, I should say just parenthetically, that independent of sexual dimorphisms, there are very, very clear-cut physiologic, cellular sex differences. And these sex differences in physiology can converge to produce the same behavioral outcome, for example, in parental behavior, or you can have the same physiology leading to very different outcomes, as is the case with the effects of stress on eye blink conditioning, for example, where stress enhances the learning of eye blink conditionings in male and has the exact opposite, it impairs it in females. So many of these sex differences that are seen are presumed to be an effect of differences in exposure to reproductive steroids, although there are efforts to link these changes to actual differences in sex chromosomes. There is this whole notion of the sexome, and then there was recently a study that looked at potential genetic determinants of sex differences by looking at the Y chromosome and mapping the Y chromosome as illustrated here, identifying a number of very interesting behavioral loci, including one for addiction to death and destruction movies, and my personal favorite, inability to express affection over the phone. So, now, as compelling a behavioral map as this may be for sexual dimorphisms, in fact, most of them do reflect differential exposure to reproductive steroids. So the question then becomes, how do reproductive steroids influence brain function? What is the signal, and what accounts for the variance in response? This is what's really critical if we're going to understand differential sensitivity. So this is cholesterol, the mother of all steroids. Cholesterol circulates in the bloodstream, bound to lipoproteins, gets into the cell, gets taken up by the mitochondria, and once it's in the mitochondria, this 6-carbon side chain gets cleaved to produce pregnenolone, which then gives rise to all of the biologically active steroids. It's critically important you remember every single one of these structures if you're going to really understand the rest of the thing. The only point is just get the gestalt of this. You see that structurally these things all look an awful lot alike despite having very, very different biological effects. And indeed, there are a very small group of enzymes that are responsible for metabolizing these steroids and producing these changes. So in addition to their largely having structural homology, I do note that testosterone is the immediate precursor of estradiol. The enzyme aromatase aromatizes this A ring, and now you've got an entirely different biological system that gets affected. So these biologic effects can be illustrated by what happens to testosterone. There's an enzyme 5-alpha reductase that breaks this double bond to produce dihydrotestosterone, which is a much more powerful androgen, which is necessary to sustain the male reproductive tract tissues like the prostate and seminal vesicles. Testosterone can be acted on by this enzyme with another enzyme, 3-alpha OHSR, that produces this compound, androsterone, which is a neurosteroid that acts acutely at the membrane to modify GABAergic and glutamatergic transmission. And as I mentioned, testosterone can be aromatized to estradiol. This takes place in the brain, locally in neurons. And this neuronal production of estradiol is actually responsible for mediating male reproductive behavior in the rat. And also remember that this local conversion to testosterone to estradiol is responsible for masculinizing the male rodent brain. Not the human, but the rodent. It is not testosterone itself, it is estradiol that masculinizes the brain. So metabolism obviously can produce a large amount of variance in a steroid signal. But how does this actually take place at a cellular level? Just as an illustration, estradiol, it's a fat, right? Because these are steroids, they diffuse into the cell. They bind an intracellular receptor. So these are not like neurotransmitter and neuropeptide receptors that exist on the membrane, but instead they exist inside the cell, and they are themselves transcription factors. Which means that when the receptor is activated, it goes to the DNA, it binds to a response element, leads to transcription of a message, and gives rise to an enormous array of proteins. So one way of thinking about what estradiol does is it orchestrates genetic transcription across a wide range of systems. It's just the protein effects. Now, unfortunately, it's a tiny bit more complicated than that. So, just to illustrate a couple of points, these steroids also have membrane receptors, and these membrane receptors are responsible for producing this very promiscuous phosphorylation, which is how enzymes activate one another. These phosphorylations will occur not only on the receptor, but also on co-regulators. The receptor, since it's very old, the receptor existed millions of years before estradiol did. So this receptor can be activated by neurotransmitters like dopamine and by growth factors. There are at least 2 different kinds of estrogen receptors, receptor alpha and beta, and they fight with each other for physiologic effects. There's also a G protein coupled receptor that responds to estrogen. But what I'm going to focus on is this element here, these co-regulators. Because it turns out that the co-regulators, of which there are about 350, determine what happens after the steroid binds the receptor. So just to provide an illustration of this, these blue balls are estradiol, and when estradiol binds this sort of red thing, which is a schematic of the estrogen receptor, it twists the receptor, it changes the conformation of the receptor, so that now this part of the receptor, this called helix 12, opens up, allows a co-regulator to bind. The co-regulator in this case is a co-activator. It brings it to the DNA. It opens up the DNA enzymatically. It recruits in a whole variety of other transcription factors. Okay? So this is an estrogen receptor modulator, like tamoxifen, for example, or raloxifene. It binds in the same pocket, but because it's got slightly different shape, it twists the molecule in a different way. So now helix 12 is here. It blocks this co-activator groove. Now co-inhibitors can bind and shuts genes off. So it's all about the shape of the molecule. That's what determines what the biological effect is. And it also suggests why some kind of estrogenic compounds like Premarin, which is a gamish of 16 or so different kinds of equine estrogens, will have a different effect from estradiol because they're shaped differently. These co-regulators not only can determine whether a gene gets turned on or off, it can also determine the sensitivity of the receptor, so it can respond to much lower levels of a hormone, and it also determines the specificity. It can make, for example, the androgen receptor respond to estrogen itself. So these co-regulators are very, very powerful in determining the outcome. And just to schematically show you what the shape of the molecule looks like, this is from work from John Katzenellenbogen. This is estradiol binding into ER alpha. So just get a look at the general shape of it. So what does the receptor look like when raloxifene, the SERM, binds it? You see it just adopts, it adopts an entirely different shape. So again, it's about these 3-dimensional shapes that determine what the biological impact is. And that's important for a couple of different reasons that I'll come to right now, which is when we're looking at sources of variation, the levels of hormone, that's going to make a difference, right? The levels of the receptor proteins, how the steroids are metabolized, because that determines what kind of an active compound gets generated. Intracellular modulators, the co-regulators, but also the DNA structure. So you can have a change in the structure of DNA that doesn't code for a different protein, but will twist the shape of the receptor differently in the same way that the hormone will shape it differently, twist it differently. Now you get different transcription factors. Now you get an entirely different effect. So that's how sort of a synonymous, if you will, coding variant can actually change transcriptional effects. And then finally, as was mentioned earlier this morning, the notion of epigenesis is really sort of critical in understanding how environment can shape the response to any kind of a stimulus. And I'll just review this since everybody knows about epigenesis at this point, but if you take a chromosome, you unravel it, you see that it consists of these so-called nucleosomes, and the nucleosomes are 8 of these histone proteins with 2 wraps of DNA around it. Okay? Now, now just consider for a moment that every every cell in your body has the same genetic complement, right? But some of them turn into skin and some of them turn into heart muscle. Why is that? It's because some genes get expressed and others get inhibited. This process of modulating these histone proteins, or the DNA itself, by adding a group like acetyl or a methyl group, takes DNA which is closed, these closed nucleosomes, it opens it up, and now the genes can be read. So if you put on an acetyl group, you open up the nucleosomes, the polymerase reads it, now the gene is expressed. If you put a methyl group on it, this is an oversimplification, but I'm an oversimple guy. If you put a methyl group on it, it closes them up, and now the genes are inhibited. Okay. This is the means by which the environment can create cellular memory that can endure for the rest of the life of the organism. This is how this prenatal programming that you've heard about can take place, and it's an extraordinarily important area for understanding sex differences. I feel the same way. It's very exciting to me. And so just as an example, if you take a pregnant dam and you feed her a high-fat diet, her offspring will choose high-fat food, become obese, develop metabolic syndrome. But that propensity exists only in the females. So how does that occur? Because exposure to high-fat food during pregnancy winds up creating epigenetic modifications of the dietary preference and of the feeding system, and that, again, has an enduring effect. One of myriad examples. I would argue this is the same thing that we're doing in psychotherapy, is that we're actually allowing the environment to reshape genetic processes. So, estradiol is able to modify the genes, modify the enzymes that are responsible for epigenesis, like these histone acetyltransferases and the methylases. Estradiol regulates that process. So estrogen has all these effects on the biology, right? But why would you think that that would specifically have anything to do with affect regulation? And the answer, quite simply, is that estradiol touches everything. Every single cellular system. I mean, it's ridiculous how many of them are modulated by estradiol. And if you look at the pathogenesis of depression, the models for same, you see that estradiol regulates every single one of these processes, whether it's neurotransmitter synthesis or metabolism. I'm just going to focus on a couple of these due to time. One is neuroplasticity. Estradiol blocks oxidative stress at the cellular level. It enhances mitochondrial respiratory efficiency, and it blocks the toxic effects of many kinds of toxins, such as glutamate excess, hypoxia, ischemia. Here's just one example from Jean Lay in my lab many years ago. These are hippocampal neurons, newborn hippocampal neurons. If you expose them for 3 days to the toxic amyloid metabolite, A-beta 31 through 35, you just kill these cells off. If you pre-incubate with estradiol for 72 hours, the cells are saved. So these are very practical effects, particularly when you're talking about Alzheimer's disease. Inflammation is very popular now. I don't like particularly the concept because now they say it causes everything, but certainly there are immune abnormalities that exist in depression. So, and this has been inferred as largely as a consequence of increases in IL-6 and TNF-alpha. But if you look across many chronic diseases, whether it's cardiovascular disease, diabetes, obesity, depression, and so forth, you tend to see a number of publications suggesting that these cytokines like TNF-alpha, IL-6, monocyte chemotactic protein are increased, and insulin resistance is increased or sensitivity is decreased. And when you look at the effects of estradiol, if you look at the effects of estradiol, you see that it actually reverses all of these processes. Again, there are lots of exceptions to this, but just as a general rule, that's what you see. And then finally, this is really where I want to focus, this idea of network dysregulation, because because this is really the level at which we can begin to better understand these behavioral abnormalities that we're talking about, and also better identify the role of sex steroids in regulating behavioral differences. So let's take a step back now and say, all right, how do we understand depression in terms of these network differences? And to do that, we've got to ask the question, how does the brain generate affective and behavioral states? What goes on? What does the brain do? All right, so we break it down. Do you all know what the brain consists of a bunch of different neurons and glial cells, right? And the nerve cells are responsible for signal processing and for the transmission of information. And then clusters of neurons then form these networks, and the networks perform neurocomputations that give rise to emergent processes. These networks dynamically assemble, which means that the same brain regions can be part of one network, and then they can separate from that network and form a different network. So it's very, very highly dynamic. And then what I'm going to really focus on now is this synchronization of neural firing, which is really what conveys most of the information. And why do I say that? It turns out that that much of what goes on in the brain, at least in my brain, is noise. Right? 95% of the neuronal firing is spontaneous, it's stochastic, it doesn't accomplish anything. So how does the brain know what's important? Well, it turns out that the way that the brain knows what is important is by neurons firing together in a coupled fashion, in a synchronous fashion. And the way that that happens is that these neurons, when, I put it this way, if a couple of neurons are firing, nothing much happens. But when more than a couple fire together, they're able to recruit in other neurons to fire the same way. So I'm going to show you two examples of how that works. So this is the first, if I can do this. Okay. So these are metronomes. They're all set to the same frequency. Okay? So what this person is going to do now is going to take these neurons that are all firing asynchronously, going to put them on these Coke cans and allow them to begin to influence each other's function. Because now when one's pulling a little bit to the right, it's able to pull other neurons and hold them there just a little bit longer, until you see that they all start firing the same way. Now, granted, this is all right, enough already. This is actually what happens in a molecular fashion, because when neurons are firing, they're altering the extra cellular ionic milieu in such a way as to prolong refractory periods that allow neurons to synchronize to one another. Now, why is this how the brain communicates? Because the brain communicates when these are all firing synchronously, you get what are called oscillations in the brain. These oscillations occur at different frequencies, and the frequencies convey information to the brain about what is important. And these frequencies will change as the cognitive operation changes. When you are focused in doing something very intently, you get gamma oscillations, they're local, they're fast. When you're sort of daydreaming about what you're going to have for dinner, you have alpha frequency, it's about 8 to 12 cycles per second. So why would the brain communicate that way? Because every single thing in our environment that's important to us communicates by a frequency. I'll give you an example. If I go like this, da, 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 what song is that? Nobody. What if I go, da, 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 right? Same notes. I assume people know what that is. But the same notes, but just the intervals, the same frequencies convey immediate information about what this is. It provides familiarity. Light is frequency dependent. Hearing is frequency dependent. The brain operations are frequency dependent. And when you go from daydreaming to focusing on something, these oscillations change. They convey information to the prefrontal cortex, which can then modulate that activity to enhance it or depress it. So how does estrogen play a role in this? In a variety of different ways. It can directly modulate the oscillations by acting on some of the neurons that convey this. And they can also do this very quickly by increasing the number of synapses. And these are temporary synapses, but these synapses will remain, they will endure if at the same time there is some activity-dependent stimulation of the neurons. So this, in fact, changes the wiring of the brain to strengthen synapses, and now you've learned something that is more powerful. So estrogen can increase the strength of these synapses, and by so doing it can increase if you will, the recruiting potential of these oscillatory patterns that convey information. Okay, so if there is network dysregulation as a model of depression, which there is in fact in depression an adaptive failure. It's a failure to be able to integrate and orchestrate network activity that is performing a number of different operations, right? You've got all these different kinds of networks that we rely on. This thing called the default mode network, which is sort of self-reflection and daydreaming. You've got social cognition network that allows you to make inferences about what other people are thinking. This is theory of mind. Reward network, affective regulation network, salience network. If these are not properly orchestrated, then what you wind up getting is interference with their operations. And that failure is in part what exists in depression, and there's lots of evidence to suggest that these networks are not operating properly in depression. So, if that's the case, then we can also, getting back to the notion of context, view the hormonal state as creating a context that actually alters brain network regulation. The way that we've gone about studying that is by using this Lupron model that Mickey mentioned. And the Lupron model is one of suppressing ovarian function with a gonadotropin-releasing hormone superagonist. You create a medical menopause, and then in that context you add back estrogen in isolation, and you add back progesterone in isolation, and you can see what the effects are, right? So we have found, in fact, looking at these networks that are dysfunctional in depression, we've looked at the effects of reproductive steroids, and here is an example of estrogen activating the default mode network, where these two critical hubs, the medial prefrontal cortex and the precuneus, you see that their activity is greatly increased under conditions of estrogen administration alone, compared with induced hypogonadism or progesterone. This is an affective regulation network. All this work is done with Peter Schmidt and others. Under ordinary conditions, which would be estrogen replacement or progesterone replacement, you see that these are correlative maps that show the correlation between prefrontal cortical activity and hippocampal activity. Under estrogen and progesterone, you see it's operating fine. Under hypogonadism, you see that these brain regions are disconnected. So their activity is no longer associated, the importance of which is that there is a top-down model of affective processing that suggests that particularly the dorsolateral prefrontal cortex can inhibit excess limbic system or amygdala activity, and by so doing allow for regulation of affective state. And the third one I wanted to show you is the reward circuitry, because one can argue, I think convincingly, that most cases of depression really represent dysfunction of the reward circuitry. That is an inability to experience pleasure with anything, and if you can't experience pleasure, what are you going to be motivated to do? Nothing, right? I mean, not eating, sleeping, sex, drugs, and rock and roll. None of it matters anymore. And further, if you can really put yourself in the position of imagining and projecting that you will never be able to experience pleasure again, it's not difficult to imagine why that leads to suicidal despair. Because you're not yourself anymore, because nothing gives you pleasure. So the way that we decided to take a look at that is Jenna McHenry, who is one of my postdocs, who works with one of my faculty members, Garrett Stuber. And she wanted to identify whether there was a hormonal responsive reward circuitry. And so we chose to look in the medial preoptic area because the medial preoptic area projects to the ventral tegmental area and to the accumbens, so that it modulates these critical brain regions that are part of the reward circuitry. And the way that she did this, the way that she did this is to use this optogenetic approach, which involves the viral-mediated transfection of these light-sensitive ion channels that are derived from algae. And the channel rhodopsin is sensitive to blue light, and if you administer blue light, it opens up the ion channel, and the cell fires, and it fires immediately, which is one of the real advantages to this. And if you put in a halorhodopsin, that responds to green light and shuts the ion channel down. So what you have is with exact temporal precision, the ability to specify individual cells that, on the basis of their genetic makeup, because remember, even whatever brain region you're talking about, it's a heterogeneous, commission of all kinds of different cells. You can identify very specific cells genetically, and you can turn those cells on, you can turn those cells off immediately by shining the light. So what Jenna did then is she put the channel rhodopsin into neurotensin neurons in the medial preoptic area, and then hooked up this fiber optic cable, which is how you administer the light to that brain region, and she hooked that up to a lever so that the rat could press the lever, and when it pressed the lever, it got a 3-second shot, if you will, of the light, turning the neurons on. If that was rewarding, then she's going to press it a lot. If it's not rewarding, you're not going to see anything, and obviously, I wouldn't be showing this to you unless something happened, right? Okay, and you can see what happens here is during proestrus, when the animal is exposed to high doses of estrogen, what happens is that the self-pressing goes way up. Ordinarily, even during other menstrual cycle phases, you may get it a couple hundred times. It goes up actually as high as 1,300 presses over 30 minutes. And is this going to work or not? I hate it when this happens. Okay. Hate the noise. Okay, so she presses it, and she's getting the light, and she's liking that. She wanders away, it stops. Come on back. Okay, there. This is an incredibly intensely rewarding experience. This is like what happens with cocaine. So estradiol has, all right, you're done. Come on. Okay. Obviously it doesn't want to leave. Okay. Okay. All right, so is there any analog for this in humans? And the answer is yes. That when we used obviously a different mode of testing the reward circuitry in humans, since we didn't want to put fiber optic cables into people's heads. But in fact, when you look at a monetary incentive delay task, you see that during the follicular phase of the menstrual cycle, the rewarding stimuli have a much more powerful effect on brain regions that are involved in reward, like the amygdala and the orbital frontal cortex, follicular phase greater than luteal phase. And these, over the course of the menstrual cycle, these changes in brain activation are actually quite closely correlated with blood levels of estradiol, suggesting again that it is estradiol that seems to be driving this. All right, so why do you think canal steroids have a role in affective regulation? It modulates every physiologic system in the world. It modulates the brain regions and networks disturbed in depression, but does it have antidepressant effects? And about 18 years ago or so, Peter performed a study in which we took perimenopausal depressed women gave them 3 weeks of estradiol or placebo. 3 weeks of estradiol significantly decreased their depression scores. Placebo did nothing. And this occurred as well in women who had no hot flushes, so that this wasn't epiphenomenal to remediation of hot flush-induced sleep deprivation. So, for a minute, it all made sense. You got perimenopause, your estrogen levels drop, you treat them with estrogen, they get better. Then along came the Women's Health Initiative, which I like to call the good, the bad, and the ugly, largely as a result of the consequences of the Women's Health Initiative. Just to review it, for those of you who haven't been on the planet in the last 15 years, Women's Health Initiative, 17,000 apparently healthy women, apparently healthy, included 8% of women who had had previous heart attacks, 34% of women were obese, 36% had hypertension, and 49% were smokers, but okay, they're apparently healthy in some world. Ages 50 to 79, half of whom received Prempro. The primary outcome measure was coronary heart disease because observational studies had shown that administration of estrogen decreases coronary heart disease by 50% in women. The primary adverse effect was invasive breast cancer because if you take estrogen for more than 4 years, your chance of getting breast cancer goes up by 30%. So what did they find? They found that coronary heart disease went up by about 30%, and so did breast cancer, and so they said, Shabbat Shalom, that's the end of it. This is the final nail in the coffin for hormone replacement therapy. Without going through all the things that are completely crazy about the Women's Health Initiative, how do we resolve this paradox? Estrogen does all these wonderful things, it blocks free radical formation, everything. So why is it causing all these horrible things? So one of the main problems with the Women's Health Initiative is timing, right? Another contextual factor, right? So if you have a woman who is 50 to 79 years old, what's the likelihood she's going to respond to estrogen? Well, the animal studies by Tom Clarkson and Phyllis Wise and others showed that if you administer estrogen at any distance from the cessation of ovarian function, you wind up not only not getting the beneficial effects, you wind up having adverse effects. And with each decade, you stand between a doubling and a quadrupling of the risk for all kinds of illnesses, heart disease and so forth. If you have heart disease and you take estrogen, you haven't had it for a while, you can destabilize plaques, you can cause stroke, you can cause heart attack. Well, they didn't pay much attention to timing. Because again, only 10% of the women in the Women's Health Initiative were between ages 50 and 54. 2/3 of the women were over 60. So that means they're at a long distance from cessation of ovarian function, which means, according to the animal studies, they're more likely to have something go wrong. And by the way, if you looked at the revised analysis of the Women's Health Initiative, when they only looked at the women between 50 and 54, they did better. They had reduced breast cancer. They had reduced heart disease. Enough already. This is what I want to focus on, which is their failure to consider individual differences in sensitivity, steroid sensitivity, because everybody wants to think about this, as a unitary experience, that somehow you get an endocrine lesion and now something bad happens. And everybody should have it. The reason that Myrna Weissman said that there was no such thing as perimenopausal depression is because all women didn't become depressed during perimenopause. Okay. Well, that succeeded in actually eliminating it from one of the earlier issues of Diagnostic and Statistical Manual, which, as I'm fond to say to Mickey, is largely a means of earning money for the American Psychiatric Association. So I'm going to give you 3 examples of what I'm talking about in terms of individual sensitivity. So this is the first that Peter took women who had a history of perimenopausal depression that was successfully treated with estradiol. All right, and so we put them on estradiol, and then half the group was continued on estradiol, and the other half was blindly put on placebo, so they've experienced an estrogen withdrawal. And what Peter found is these are weekly mean mood ratings. You see that the women who were continued on estrogen did great, and the women who were withdrawn almost immediately began to experience depressive symptoms. And by the way, these symptoms occurred antecedent to the development of hot flushes. Okay? So that looks like estrogen withdrawal causes perimenopausal depression, except If you take women who had no history of perimenopausal depression and do the exact same manipulation, there's no effect on mood whatever. So that means, again, that there's a group of women for whom estrogen withdrawal, or declining estrogen, is responsible for precipitating depression, but it is a subgroup of women. All right. And a second study, a wonderful study that was performed by Mickey Bloch some years ago, which is a classical study now. Mickey took women who had a past history of postpartum depression, and he did the same sort of study. Stabilize their endocrine milieu with a GnRH agonist, add back high levels of estrogen and progesterone to create a scaled-down model of the puerperium. And what Mickey found is that during hormone add-back and during withdrawal, there were dramatic increases in depression symptoms. These are the Cornell-Dysthymia scale. But again, in women who had no history of postpartum depression, there was no effect on mood. Remember, these women who had a history of postpartum depression were euthymic at baseline, right? So he exposed them to high-dose reproductive steroids. They get depressed, but another group, no effect. So again, a differential sensitivity. And this finding has recently been re-examined by Crystal Schiller, who works in our program. And she did a similar kind of study, except that, again, sort of suppressing ovarian hormone function and then adding back high dose of estrogen and progesterone, but also obtained fMRI during baseline and during withdrawal. And Crystal replicated Mickey's findings. Again, the red is hormone add-back, and the whatever color that is, purple is hormone withdrawal. And you see a dramatic increase in symptoms of dysphoria and ill temper and whatever that is, panic. But women who had no history of postpartum depression, you simply don't see the effects of the modulation of their reproductive endocrine levels. Additionally, although all women experienced an increase in their reward circuitry with this monetary incentive test, there was one, all women showed that. 2/3 of women showed this. That is, 2/3 of the women with a history of PPD showed this kind of response, but 1/3 didn't. And so if you compare the women who did experience that with the women who didn't, you should be able to get a marker for endocrine sensitivity. And what Crystal found is that there's an area of the prefrontal cortex and the anterior cingulate cortex, which, as you know, is critically involved in sort of self-monitoring and affective regulation. Overactivation of that at baseline predicted those women who are going to respond to this hormone manipulation by developing depression. And finally, the last example of this is, we'll call it PMDD. I love the question about the difference between PMS and PMDD, because I don't think functionally there is one. But it got created as something, the people who come for help are not, by and large, somebody who's coming complaining of breast tenderness. They come because they're having mood symptoms, and mood symptoms can be demonstrated to vary with a menstrual cycle, as Enbal described. And so this says PMDD, but you could also substitute PMS for this, as far as I'm concerned. Anyway, so these are weekly mean mood ratings in women with PMS at baseline. You see during the luteal phase, you see an increase in symptoms, and then they're fine for 3 weeks, and then it comes back. If you suppress ovarian function in these women in whom you have confirmed PMDD, because that's the critical element in PMDD or PMS, is confirming that there is a luteal phase constrained appearance of symptoms, because about 2/3 of women who will report that history will not have it when you follow them longitudinally. You shut off ovarian function, and by the 2nd and 3rd month, the symptoms are gone. They do not appear. If you give them placebo, conversely, the symptom cyclicity and severity is present. So, okay, that looks like ovarian hormones may be playing a role. But if that's the case, let's add back the ovarian hormones to these women who responded to the lupron, to ovarian suppression, by having symptomatic remission. And when you add it back, you see that compared to the ovarian suppression, when you add back either estrogen or progesterone, you get a significant return of symptoms. So that looks like estrogen or progesterone is capable of producing affective symptoms in women with a history of PMDD, right? But, again, perform the exact same hormone manipulation, everything the same, levels the same. In women who have no history of a menstrual cycle-related affective syndrome, you get no perturbation of mood at all. Right? So again, it is this differential sensitivity. You can demonstrate it by manipulating the endocrine system. Now, notice that the symptoms seem to be going away on their own account. So that leaves a question. And the question is, are the symptoms precipitated by adding back the hormones? Now you're getting a change. Or do the levels of hormone have a permissive effect that allows some kind of infradian Zeitgeber, some kind of clock, monthly clock, to express itself? So we designed a study in which we administered Lupron for 5 months. So here are the baseline symptoms. Now, if this is due to a change in the hormones, you would expect to see the symptoms occur, but since the hormones thereafter are stabilized, you will see no further return of symptoms. If, conversely, this is due to a permissive effect of the hormone levels, you'll see the symptoms come, they go away, then they're going to come back again. All right. How many people think that it's due to differences in hormone levels? 1. How many think it's due to a change in hormones? 1. How many people have no cortical activity at this point? Just trying to get there we go. That one won. So, well, it turns out that the one who suggested that it was due to a change in hormones is exactly right. So these are bi-weekly mood ratings. You see the symptoms at baseline, and then with ovarian suppression, the symptoms disappear. You add back placebo, nothing happens. You add back estrogen, progesterone, the symptoms dramatically appear, and then they're gone for the rest of the 3-month period. So it's a change in the hormones. This is what an individual person looks like, because again, you're looking at group mood ratings that sort of spread out a little bit. But you can see quite a substantial increase in symptomatology that then subsequently disappears. Okay, so if it is a change, okay, let's say it's the change that's driving this, you still have to account for the fact that this is a differential effect, because the same changes don't produce any mood symptoms in other women. So, if that's the case, is there any evidence of a differential brain effect of these hormones in the women who show the sensitivity, the women with a history of PMDD versus control women? And again, I wouldn't show it to you, I wouldn't set it up this way if there was nothing, but these are, again, the 3 hormone conditions that I mentioned in Lupron. So this is hypogonadism, this is estradiol replacement, this is progesterone replacement, this is the subgenual cingulate, again, one of these affective regions. You see no effect. In women with PMDD, you see a very large effect, particularly between hypogonadism and adding back progesterone. And you see the exact same thing in the medial orbital frontal cortex. You see this stepwise effect of hormone replacement. So the brain is responding differently, but only in those women who have a history of this disorder. All right, so what is it that causes the susceptibility? Well, again, thinking about context, the most obvious explanation is the genome. And I mentioned the sexome earlier. It really is sort of, it's critically important for really interpreting some of these effects. But when we think about the genome in psychiatry, we usually sort of think about, sort of these traits. Jimmy's 6th generation pain in the ass, they sort of get transmitted across a variety of generations. But what I'm talking about is a genetic predisposition to respond differently to the same stimulus. And by the way, this is a really critical point. And that is that there are these reactive alleles. And these reactive alleles result in what are called orchids and dandelions. And so the orchids who have these reactive alleles, which you can measure like really increased autonomic activity, these kids who have this are susceptible to all kinds of illnesses, immune dysfunction, under conditions of adverse childhood experiences. But if you take these same kids and you put them in a good environment, they do better than kids who don't have these reactive alleles.
So these reactive alleles, in a way, can be beneficial in terms of really providing adaptation and allowing for really great things under good conditions. But under bad conditions, they really suffer. And they learn, if you will, adverse healthful effects. So we decided to look at potential genetic contributions to this in two different ways. Am I right? First is we did gene-based haplotyping. We looked at 5 genes, and this is estrogen receptor alpha, called ESR1. And we hope to find some connection between a single nucleotide polymorphism and perhaps an intermediate trait. But what we found instead were 4 SNPs, 4 of these structural variants in the 4th intron of the estrogen receptor alpha in women with PMDD. Now, why is that interesting? It probably isn't to most people, but why? Because estrogen receptor alpha, this finding that we have occurred most significantly, most strongly in women who had another genetic variant, which is called the COMT Val-Val polymorphism. So COMT catecholaminyl methyltransferase. This Val-Val polymorphism is one that makes excessive activity of the enzyme. That's the women in whom we found this. Now, it turns out that estrogen receptor alpha modulates the activity of COMT. There's an estrogen response element on it. And COMT metabolizes estradiol. And then additionally, COMT, particularly the Val-Val polymorphism, regulates prefrontal cortical dopamine. There's no dopamine transporter in the prefrontal cortex. So the Val-Val polymorphism results in too little dopamine in the prefrontal cortex. And I showed you a little earlier that estradiol regulates prefrontal cortical activity. So that seemed kind of neat. So if there is this genetic variant, and this genetic variant seems to have something potentially to do with prefrontal cortical activity, can we find evidence of a physiologic trait abnormality in the prefrontal cortex in women with PMDD? And the answer again is yes. So these are both PET scans and fMRI scans. This shows the difference between women with PMDD and controls. And so in this particular case, you see this dorsolateral prefrontal cortical activity is enhanced in the women with PMDD relative controls. And here you're showing correlations between this prefrontal cortical activity and symptoms in women with PMDD. And you see that the higher the symptoms, the higher the activity in this prefrontal cortical activity. Now there's one other way that we've approached this, if you will, sensitivity, special sensitivity, by trying to identify cellular differences in the response to steroids. And so what Peter and Dave Goldman did is took women in whom we demonstrated the hormone sensitivity using our Lupron model and control women who have no changes. We took their cells and we created lymphoblastoid cell cultures, and then looked at baseline differences potentially in lymphoblastic cell cultures, and then also looked at how the cells responded to administration of estrogen and progesterone. And this is an impossible slide, so you get a gestalt. But the answer is, when you do these so-called gene ontology measures to try to identify pathways that may be differentially activated in women who have this steroid sensitivity and women who don't. One pathway that stood out is this ESCEZ complex, which is a polyclonal pressure complex. This is an epigenetic modifier. And it's not a single gene that is modified in this group. It is multiple genes. This is actually an earlier version of it, but it was 8 out of 13 of the genes were overexpressed in women with PMDD at baseline. And then additionally, you actually see, without the details are irrelevant here, but get the, again, just a general idea that the cells themselves, when in vitro, when you expose them to steroids, respond differently in the patients and the controls, suggesting that we may be able to identify at a cellular level this issue of steroid sensitivity. And so the last context that I wanted to mention again is simply this. As was illustrated in the talks earlier today, it's stupid to talk about gene-environment interactions because every gene interacts with the environment. That's the whole notion of context, and that you can't interpret a genetic effect absent an understanding of the environment. I mean, that's probably an overstatement, but, you know, work with me a little here. It works better that way. So it's really critically important to realize, for example, that changes in serum T and BDNF that you can show in animals cause cognitive effects will not show the same cognitive effects if you look at it in relation to phase of the estrous cycle. So you can see an effect of the gene, you can see an effect of the estrous cycle, you put them both together and you don't control for it, you get nothing, and I'm going to beat the 5 minutes. So let me give you one example of that, of this gene-environment interaction with some work from Istvan Modi, and he has an animal model in which he developed an abnormality in the delta subunit of the neurosteroid receptor, basically the GABA receptor. Okay? And this, the animals who have this look absolutely normal until they deliver. And once the animals deliver, they wind up cannibalizing their pups and developing what looks like a postpartum depression. You heard about the forced swim test. So normal animals with a genetic abnormality, they get into a particular reproductive state. You get an entirely different behavior. And this abnormality has nothing to do with the pups, because if you cross-foster the pups, it's not like the pups are weird, and so the mothers are now, these pups are going to eat them. It's that they'll have the same response to pups that aren't their own. So this is an example of a reproductive state determined expression of a genetic abnormality. So, in sports first, the New York Rangers lost last night 3-2, but claimed victory anyway. This is complicated. It has to be complicated. We're complicated. I mean, and we shouldn't expect anything less. But if we really just embrace that complexity, embrace the differences between our patients, and not try to put them all into the same box, you know, as illustrated from this page of the Annals of Equine Medicine, where no matter what somebody comes in with, you have the same therapeutic response. If we can just, as I say, sort of embrace that variance, we'll be like T. Albert Fenster in the right place at the right time, because we have these wonderful tools for being able to, if you will, dissect the complexity of biology. And if we do that with the right conceptual models, recognizing that we always, and particularly as psychiatrists and people working in mental health, we always have to attend to the environment, to the context, the antecedent context and the current context, then we're really going to be in a position to be able to develop new treatments and help our patients. Thank you very much for your time.